system strengthening. And then what we can do differently is I'd like to introduce a few economic arguments that we need to use in order to make arguments for improving our workforce. So I don't think I need to convince the audience here that we need healthcare workers. All of the research that we have done shows that as we increase the number of healthcare workers, of course, the survival of everybody improves. And you can see here, most importantly, women and children. However, the problem is that we spend a lot on healthcare workers. You can see here that in many countries around the world, upwards of 60% of our spending goes to worker salaries, which means that we need to raise lots of money in order to pay for our healthcare workers. And as you can see here, this is very difficult to do in many countries around the world. And this is just showing you that in order to meet an old indicator, which was the WHO indicator of achieving 2.3 healthcare workers per 1,000 population, countries around the world would have needed to increase the amount that they're spending on healthcare, upwards of 50 and 60% of total healthcare spending would have had to been spent on healthcare workers. And I'll come back to Ethiopia at the top of the screen there, which would have been impossible. And the benchmarks just become harder and harder to reach. These are new benchmarks according to the universal health coverage and new benchmarks according to the social sustainable development goals. Okay, so what should we do differently? And I think many of you are already doing this. And if you've come to any of our courses, Dr. Ghaffar has joined us at Harvard. We talk about health system thinking. And I'll introduce to you one framework that we use to think about system thinking. And I think many of you in your countries are already doing this. And the second thing is you need to arm yourself with economic arguments in order to convince the decision makers that investments in human resources are good investments to make. So this is a framework that we use at the Harvard T.H. Chan School of Public Health. And this is a framework that we teach in any of our courses. And if you'd love to join us for any of our courses, I'll give you some information at the end. And you can see here that in order to improve healthcare systems and improve our workforce, we need to think about our system as a whole. How does your system work? How does it function? And on the left-hand side, we have all of the different ways that you can influence your healthcare system and make changes in terms of financing, in terms of payment, organization, regulation, and behavior. And so we have to think boldly about how we can make these changes. And many of you are doing these already in your country in order to measure and understand how we're making system changes to improve all of the things on the right-hand side, which are health status, customer satisfaction, and risk protection. I think for human resources too, we have to think about markets. Most importantly, we have to think about the labor market. And this here is another framework that we use to understand the total number of healthcare workers that are available in your country. What are the demand and the supply side factors that impact their work in your country? For example, on the right-hand side here, you can see all of the different ways that the demand for healthcare services and workers are impacted. Demography, healthcare utilization, delivery models, which all of you are just talking about in the previous lecture, which are so important, but you have to make sure you understand how that impacts then the demand for healthcare services. Also taking into consideration on the left-hand side, the supply of healthcare workers in your system. And this can be at the national level and can be at the state level. It can be even at individual facilities that you're working. So just to finish up, I'm just going to talk a little bit how we can think about these things differently. by arming ourselves with economic arguments. And I'm going to use an example from Ethiopia, an example that probably all of you know, one of the largest community healthcare worker programs in the world, the Health Extension Worker Program in Ethiopia. I'm not going to talk about the Healthcare Extension Worker Program because everybody knows about this program, I'm sure. What I'm going to show you is an example of how we used an economic tool, return on investment, to understand what is the return on investing in this extremely important program. Just to set the stage, I think Ethiopia is a similar country, maybe to some of the countries that you're working in. And when we began working in Ethiopia many years ago, it was a very poor country, low number of healthcare workers, high maternal mortality rate, very few women delivering in healthcare facilities, high spending on healthcare from people's pockets, and poor quality care. Some of the issues that were just referred to in the previous presentation. And so the Health Extension Worker Program, as you all know, was put in place to solve some of these problems and to fill that human resource gap with lower level health cadres, these community health workers, which they called health extension workers. These workers were trained for 1 year and they were paid during this time. There were minimal levels of education. Many of them were women, and they learned basic health care skills and packages that they could offer at the very lowest level of the healthcare system at the community level. And so what we wanted to do was not only evaluate the effectiveness of this program, we wanted to arm ourselves with economic arguments and determine what are the benefits, the economic benefits of investing in this program. Because the government, the World Bank, USAID, the Bill and Melinda Gates Foundation, all made very large investments in this particular program. And so we wanted to understand and come up with a framework to measure the impact of this program. And so this is the framework that we came up with, and you can develop similar frameworks for all of the important programs that you're working on to understand the value. And the framework here was very simple. We just said, well, there's going to be some costs to implementing this program on the bottom of the slide, but there could be lots of benefits. And you can see here, most of the benefits that we measured were for moms and kids. But you can see here that we measured benefits, and this is why you have to arm yourself with these economic arguments. There were clearly health benefits, which led to productivity, but there were also economic benefits, empowerment benefits, and employment benefits, all adding up to a simple return on investment, which is the benefits divided by the costs. So these were the main benefits that we measured, and we measured these in coordination with the government and those that were implementing the program to understand the impact of these investments. And you can see that clearly there were lots of health benefits, that women and children were living longer because of the benefits of the Health Extension Worker Program. We also measured important social benefits. And I think it's really important to take into consideration when you're doing these evaluations, not only the health benefits, but also the broader social impact of your programs. And so 2 social impacts that we estimated were 1, equity benefits. What were the cost offsets for women and children and other family members of visiting a health extension worker in their village, rather than having to go to a higher level healthcare facility and spend more out of pocket for those services? And same on the empowerment side. Women may feel more empowered to visit someone in their local village rather than going to a healthcare provider that they may not know very well. Clear employment benefits to not only the health extension workers, and the government employed upwards of 45,000 new employees. But there were also benefits as well at the village level, in that some of those economic impacts were returned to the village level. And then, of course, productivity. And then if we're healthier and women and children are healthier, they will return their productivity back to Ethiopia. So that was the simple framework that we used. And we were able to calculate all of those returns in economic values. That's the sum of the benefits, health, social, and economic, divided by the sum of the costs, which was the cost of implementing that program over this 10-year period. And we were able to come up with a simple number that then makes it very easy to argue that this program was impactful. Here's a picture of me in Ethiopia with all of my data collectors. We had to collect a lot of data from our healthcare facilities and some of our health extension workers. And I'll just give you 2 slides on the results. And you can see here that they employed lots and lots of health extension workers over this 10-year period, a really big program. And you can see this is the total number. And then each of the lines at the bottom are the 4 states where we did the analysis for this study. And then I won't go through all of the results, but you can see here that these are the main results for the analysis. And you can see that the benefits are on the left-hand side for all of the states, and then the total benefits and dollar values. And then on the right-hand side, we incorporated 2 economic evaluations, a standard economic evaluation, and then evaluation that also included the value of a statistical life, which I won't go into details on what that is, but it is another calculation to understand the impact for individuals on your program. And you can see here that we're getting almost a $4 return on the investment in this program, taking into consideration all of the benefits. And that's a pretty good investment for healthcare. It's hard to get a very high return on healthcare because there's a lot of variation and variability in what we measure, but almost a $4 return is a robust investment in a healthcare program. So this is just one example how we can do things differently, arming ourselves with these economic models. So if you're interested in learning more about some of these economic arguments, please come to some of our programs at the Harvard T.H. Chan School of Public Health. I think some of you have attended. And we'd love to talk about all the great work that's going on in your countries. We have a program on decentralization, a program on strengthening human resources for health, and a number of you, including Dr. Ghaffar, has attended this program. And we also have a new program with Margaret Crook, thinking about quality of care. And I know a lot of you are thinking about quality care. Margaret Crook takes a system perspective on this, thinking about high quality health systems. How can we improve our health systems, taking quality into account as well? So in conclusion, arm yourself with economic arguments. You're going to have to be fighting for dollars for your programs, and also think broadly about your healthcare systems, taking into consideration health system strengthening as you're doing that. Thank you very much, and I hope you have a wonderful conference.
All right, thank you, Dr. Diana, for your presentation. So right now we are going to commence the panel discussion for today. And for the first panel discussion, our facilitator is going to be Dr. Chinekwe Ore. He is the health advisor for Nigerian Governors Forum. You are welcome. You're welcome. You're going to introduce the
Good afternoon, ladies and gentlemen. I would thank you for this opportunity. We're about to go into the first panel session for today, which will still be looking at what we had in the first technical session around using data and technology to optimize health resources. I'd want to invite, first of all, the chairman for this session, who is the Honorable Commissioner of Health from Nasarawa State and the former Executive Secretary of the Nasarawa State Health Insurance Agency, Dr. Gaza Wamna. Please, let's keep clapping till he gets here. You're welcome, sir. Okay, and then we also welcome Dr. Jimmy Aribobuo, the President, Healthcare Providers Association of Nigeria. Dr. Prince Agbo, Health Policy Research Group, University of Nigeria, Nsukka. Let's keep clapping. We have Dr. Baba Gana, the Executive Secretary of Yobe State Contributory Health Management Agency. We have Dr. Njide Ndili, the Country Director of Farm Access Nigeria. Then we also have Dr. Folarin Olashoba, the Medical Director, Health Connect Nigeria Limited. Joining us online will be Mr. Oluchukwu Obele, who will be representing the Country Director, Christian Aid UK Nigeria, Temitope Fashola, who had to leave for some other engagement. So I guess Mr. Oluchukwu Obele is online now. All right, thank you all so much. So like I had said earlier, this panel session is going to be taking a further deep dive into the use of data and technology to optimize human resources. From the first three sessions we had today, the presentations showed how data and technology has been helpful in optimizing resources. But unfortunately, there was no Q&A session to help to have a further deep dive into those discussions. But fortunately, this panel session provides an opportunity for that deep dive, where we'll hear the panelists share some practical experiences from the field and the policy implication for those lessons. And first of all, the first question I have here will be directed to Dr. Jimmy Aribobuo, who is the President, Healthcare Providers Association of Nigeria. Having been working in the private space for a while, so this question is to help us to have an insight on the practical approaches to optimizing private healthcare providers' contribution to the health system development. So could you kindly explain to us practically, how do we optimize the private healthcare providers' contribution to health system development? What do we need to do differently?
Thank you very much. I've done 2 terms as National President of Healthcare Providers Association of Nigeria. So I'm the immediate past National President and now the current National Chairman, ICSIPAN Committee on Health Insurance, just to put that in right perspective. Well, the private sector, private healthcare sector, we have always advocated and stood very firm on public-private partnership, PPP. And again, when we look at resources, in this situation, we're talking of man, materials, money, machine, and so on and so forth. And we have actually seen also that there have been wastages for quite a while. And what was the cause, or what is the cause? Everybody wanting to do solo things. In a situation where you actually would not even need a CT scan machine. You see CT scan being planted. You see even cancer therapy machine being procured and almost being planted in areas where you even hardly have an oncologist. You see MRI machine ditto. You also see on a street, even when you come to primary care level, of 3, 4, 5, 6 facilities. Everybody procuring X-ray machine. And some of them developing cobwebs because they have not been used for months or years. And when I looked at it, is it not possible to go on synergy? Is it not possible to have a common area of surgery? For example, a common medical theater where you can actually collect all the patients who need surgery and go into what we call health care group practice. And you need to get me clear. I'm not saying medical group practice. I'm talking of health group practice. There's a difference between the two. The medical one is just about doctors. But when you talk of health group practice, you bring the conglomerate of all the stakeholders, of all the people that form that health sector, nurses, pharmacists, dental surgeons, name them. And you may end up having one roof stop or one shop stop where you have a mega unit, a mega environment. You don't duplicate reception. You don't even need to duplicate your mechanical generator. These are things we looked at. And we also found out that sourcing and paying for energy is been a big problem. Now, it's okay, the solar system, what can we do? And what can also be possible in trying to reduce even medical tourism outside the country? What can we do in looking at the non-functional primary health centers of the government? That we have them in hundreds and droves, and they are not working. There are retired medical doctors, for example, who are retired but are still energetic. If you do a PPP with them, even at their 60s, even 1970s, they can take care of all the primary care issues. And these are ways to maximize, or let me say, optimize our resource utility. The procurement system, we need to look at it. In fact, we need to look at audit. We need to look at statistics. We go into the private centers or private hospital facilities and ask them, what are your referral cases like? What's the nature, your morbidity, mortality? What have you done this quarter? And monitoring and evaluation will go a long way to encourage optimization of these resources. Why are people just interested? Okay, I'm sorry to tell you this. In the National Assembly, if you say you want to start procuring, you don't want to do digital, they are so happy you don't want to do digital because some people will go in there to buy certain things. Immediately the digital is over, the procurement is over. Somebody says, okay, now can we go the old system? So I don't want to talk much on that. It's about something peculiar to us, which we all know. I'm picking National Assembly, for example. I'm not particularizing any group. It's about all of us because we're all stakeholders. It's also happening in government circles. So I think for now, we are set more than ever before, the private sector, to join hands with the government of today to make sure we reduce areas of wastages. Even in drugs and pharmaceuticals, we encourage people first in and first out to be used. Not that people should wait, intentionally procure drugs that are nearing expiry date, intentionally doing it. And at the end of the day, we burn them off. These are some of the areas we have seen. We provide 60 to 70% of the healthcare patronage of the population, while in government unit, it's only about 30%. And I want to finalize this particular commitment here, that in 2016, 2017, we did our own research in the General Medical Association. We found out that we had 40,000 doctors practicing in Nigeria. And then population was about 170 million people. 28,000 doctors, which form 70% of that 40,000 doctors, were practicing in urban areas. That was only 30% of the population. 30% of that 170 million is 50 million people. So you see 28,000 doctors attending to 50 million people. And then in the rural areas, you see 70% of the population, which is 120 million people. They're only being attended by 12,000 doctors. There is this skewed thing which we must redistribute. And this is just what I want to give as an example. So patient-doctor ratio or doctor-patient ratio in Nigeria today is about 1 to 10,000. And that for the nurses is about 1,600 to one nurse. It is really, really a skewed distribution that will not be so good for our system. Private sector, we are determined to make sure we reduce wastages. Thank you.
Okay, thank you very much, sir. one striking thing from what he said is that there is a need to leverage public-private partnerships. And when Dr. Ndili was making her presentation earlier, she had actually cited examples of some of the successes recorded in Delta State from the PPP arrangements, which Farm Access supported them in. And she also mentioned other areas in which they have leveraged tech to optimize resources. So I'll be directing the next question to you, ma'am. Based on the successes that you have recorded so far, and based on the need to, scale these successes up, what do you think? How do we go about accelerating the adoption of optimization enabling technology in the health sector? So how do we get to scale some of these successes and some of these technology optimizing solutions that you had discussed earlier this morning?
Well, I think it's a tough question from the point of view of my last slide, which is the political will. First of all, you have the political will because you have to anchor it in government. But the second thing is knowing that you don't know what you don't know. All right. The point being that oftentimes we design systems and we expect that we can cut and paste the systems. But before you can transpose a system, you actually need to understand the environment in which you're trying to put that system into. What works in Lagos may not necessarily work in some of the states in the north. So that's the first thing. The second thing is understanding who the key players are. Yesterday, I was fortunate enough to engage the Governor's Forum, Dr. Wahab, in a meeting stating that, some of the successes we've recorded, we want to see how we can push it down to some of the states. Regardless of the policies you make at the national level, the implementation is within the state. As you know, for health, most of the states have their own health insurance systems that run their health insurance programs. So you can't take a solution from Lagos like we've done and plug it into Nasarawa. I have to understand what's happening in Nasarawa. So first is the engagement. Understanding the environment, what exists, understanding the players and what exists, and then trying to find a solution or a way to integrate. What are you lacking? Like I said, I don't want a situation where we're reinventing the wheel. Can we enhance what is already existing? Do we need to understand how their system is being run so that we can then plug in where the gaps are? Then critical is what is the common coding methodology, if I call it that, the language between the players. Right now, if you go to some states, they're using ICD-10, ICD-11, some custom codes, and so on and so forth. ICDs or DRGs, so many different codes. Who is responsible to determine or to, I don't want to use the word legislate, but there has to be a common language amongst the different stakeholders. Again, this is one of the fundamental issues why we are not able to really use the data and analyze it. If you go to some of the states that we worked in, you see how they record encounter. Some in longhand, malaria, plasmodiasis, malaria/typhoid, and so on and so forth. It's impossible to analyze. So in a sense, what I'm saying is that every state is unique. Study what already exists within the state. If nothing exists, even better, because you can then leapfrog and then give them a system and a solution that works. But if there's already a system, how can we enhance it? How can we, who is the point person, who has ownership, and so on and so forth. So it's a very complex problem because most IT solutions, 90% of them fail. Cost a lot of money, and so on, even in developed countries. So it's a very, very peculiar, meticulous system that you don't go in a rush. I myself, even though they keep calling me doctor here, my background is computer science. We look at healthcare in numbers. Without the numbers, you can't make any sense of it. How many people went to the hospital? What were their conditions? How can you code it in such a way that you can analyze it, and so on and so forth? So until we begin to see data as critical to enhancing the healthcare system and putting in systems that, not even big, huge systems, simple solutions that just capture what we want in terms of analysis or in terms of scale, in terms of transparency, fund flow. I don't think we're going to make much progress. I know I've said that before, but back to the point is situational analysis, identifying who the key players are, understanding what already exists within the state, and then looking at ways to enhance it with light technology that can easily be maintained locally, not some highfalutin systems that we often procure from overseas. We have really talented young people here that can program some of these systems for us.
Well, thank you very much. Very insightful comments there. The need for situation analysis, understanding that there is no one size fits all solution, adequate engagement of all relevant stakeholders, leveraging on existing structures and systems in whatever state or location that we want to go into. So thank you very much once again, ma'am. I want to direct the next question to Dr. Prince Agu, who is from the Health Policy Research Group of University of Nigeria and Nsukka. So I know that you do a lot of research, you have a lot of data, you have a lot of information, and normally there is more or less a disconnect between policy and research, particularly in this part of the world. So I think this is an opportunity for you to share with the people in the room on how some of the research that you have been carrying out in the Health Policy Research Group can come in handy, come in helpful with regards to optimizing resources in healthcare. So my question is, what are your specific recommendations for policymakers, development partners, CSOs on key actions for curbing corruption in the health sector based on the work you have been doing, based on the evidence? What are specific recommendations? Because we understand that one of the reasons why resources are not optimized is because of the leakages in the system. And if we're not able to find ways to plug those leakages, we will not be able to optimize our resources. So could you kindly share some recommendations?
Okay, yeah, all right. Thank you so much. A very interesting question. So at the Health Policy Research Group, we do lots of research, and study in corruption and anti-corruption dates back to 2017. So it's been about six years where we've been looking at corruption and anti-corruption, particularly in the primary healthcare system. And so I would talk more from the primary healthcare level, because my engagement with the tertiary level of healthcare has been more around procurement. So some time ago, we studied pharmaceutical procurement in the tertiary level of healthcare. But however, I would leave that and speak more to my area of strength, which is the primary healthcare, and I'll leave the experts to pick the lessons and see how they can apply to other levels of healthcare. So first, it's for us to, I love the last presentation by Diana, and where she made mention of systems thinking. Importantly, we've not been able to achieve some level of pulling the system together and thinking in some way that would reflect the system. And if I want to teach system, if I want to talk about system, I usually use 3 levels. There's a publication by Brownson where he described the system across 3 levels. That's the upstream, the midstream, and the downstream, and I'll explain. And I'll start from the downstream. So the downstream is more like reactions of health workers to what you have at the midstream and what you have at the upstream. And at the upstream, you have the comprehensive and total political economic management of the entire system. So that's where you have lots of policymakers, the minister, the commissioners for health, the head of health units at the local government level. So that's where you have them. And then at the midstream, you have the facilities themselves. So that's the facility managers. With respect to primary healthcare centers, you have the officers in charge. Now, we keep complaining about healthcare workers, corruption at the front line, from absenteeism to informal payments, to medicine theft, to procurement-related corruption. So all of these things happen at the front line, and we know they are very damaging, especially in poor settings that would have to rely on just the primary healthcare centers. And so we fail to understand that these corruption happening at the front line, if you put all of them together, they are just more like reactions to defects in the system at the midstream and at the upstream. And I'll start with the upstream. When Dr. Gaffer was making his presentation earlier this morning, he made mention of we understanding what doesn't work, and then we move from the concept of what does not work to create those solutions. Now, at the upstream level, one problem we found is the fact that there's an absence of rules. The health sector, it's a very unique sector. And sometimes I wonder how people try to want to take the civil service rule and implement in the health sector. The civil service rule does not make provision for shifts. The civil service rule does not make provision for procurement of consumables, and all that. And in the wisdom of those that designed the Basic Healthcare Provision Fund, they required the states to provide some kind of PHC handbook, that stipulates some sort of rules for the primary healthcare system. I've been to one of the states where I asked of that, the rules they designed to attract the Basic Healthcare Provision Fund. And disappointingly, they said, we have those rules, but we don't have the money to print them. And, I looked at it and I was like, so that means that currently the PHC system seems to be moving into a state of anarchy. And it's moving into a state of anarchy gradually because the rules are not there and the rules are not clear. Two, it's a factor of addressing some of those systemic defects that justify why people are corrupt. An example is the issue of security. And that's why I usually make reference to the health in all policies. I've been to a facility where a woman gave birth in that facility, and as soon as she gave birth, hoodlums attacked the facility and took away her child. And everybody in that community stopped patronizing that facility, even if by chance they go to that facility. And once they give birth, they are trying to run away. And you look at that health facility, just directly next to it, you see some hoodlums smoking marijuana, just very close to the health facility. And we had to write the paper on how insecurity in health facilities are actually threatening, the delivery of healthcare. Now, you see, if you go to those facilities, the health workers have justifiable reasons not to come to work. And they are saying, we aren't coming to work because severally we've come to work and we felt threatened. And that's why we had to coin a kind of corruption, survival corruption, where people who do not just want to get corrupt because they need to survive. And you equally find this thing happening in terms of when you do not pay people salaries on time, or you pay them very little money, and then you see they need to do some other things, and they are telling you, I'm doing these other things because I need to take care of my kids, I need to pay bills, I need to take care of my health, and all of these things. So if we look at the upstream level and all of the policy issues, from having clear rules, making sure that those rules are cascaded, to the health workers. In fact, we've done a research where health workers said that they can't recall the last time or remember the last time that they did orientation for them. So people just get employed and they are asked to go into the system, and there's no orientation, nobody's teaching them anything, nobody's telling them anything, and they are expected to deliver healthcare services. So these are the issues at the upstream that we must address if we would tackle corruption. And then at the midstream, you now talk about how the facility managers are selected, and even more so, how the heads of the health units in the local government are selected. A an executive secretary in one of the state primary healthcare development agencies said to me that he got into the system and discovered that people who are heading the health units in the local government do not know how, some of them do not know how to send emails. And it speaks to competence. And so what he did was to set some form of examination assessment, and so that he could select HODs. But what happened was that he couldn't implement that idea of his because the powers that be had to clamp on that decision and said to him, you need to revert to to go back to what the system wants. And what the system wants are people who become HODs or people who become OICs, one, because they are connected, two, because they are the most senior. The most senior doesn't really guarantee that they are the most competent. But whereas you have very competent people who are there who could man these, positions and of course deliver quality leadership. And that speaks to the issue of political interference, undue political interference. We need to come to a level where we look at the healthcare, yes, as part of the political unit, but then we equally look at the healthcare as something that shouldn't have elements of political interference, undue political interference. And you would ask me, has that ever been possible? Yes, it has. Let's look at Dora Akunyili's time when she was the DG of NAFDAC and what she did. Because of the fact that there was that absence of political interference, we had a case where she successfully reduced flow of fake medicines, substandard medicines in the system from over 80% to under 10%. So it shows how if we look at our healthcare system from a point of asking ourselves, what are the systemic issues that would, one, make people to be corrupt at the downstream, two, make people to provide justifications to be corrupt at the downstream, and three, make people not to regard the system, then I think we can now say that we actually have an anti-corruption plan. Thank you.
Thank you very much. That's a very detailed feedback. It goes back to strengthening the system. Thank you so much. I want to quickly go over to Dr. Baba Ghana, the Executive Secretary of Yobe State Contributory Health Management Agency. We had received a presentation earlier by the Director of Programs where he talked about the use of data by your agency. So I just want to ask, how has the use of evidence generation, because I see that you've generated quite a lot of data, how has it helped to improve, to help you get more value for money in your agency?
Okay, thank you very much. As a new agency, recently established, what informed our decision to carry out this very important and strategic survey is because of a lot of feedback and complaints we'll be getting from enrollees, ranging from low service utilization, non-availability of drugs, poor access to quality healthcare services. So as an agency to mitigate these challenges and also for an evidence-based decision-making, we, as an agency, we developed our 10-year strategic plan. Of course, under the leadership of our Honorable Commissioner, we developed the 10-year strategic of the agency, and we developed the AOP to operationalize the strategic plan. And we contacted the DGI for them to carry out this very important surveys in the state. And for the 3 surveys that was carried out by DGI, the client satisfaction survey, fiscal analysis, and outcome survey. For the client satisfaction survey, the survey measured survey indicators of satisfaction, which enabled UHMA, which is the UHC Contributory Care Management Agency, to be more targeted in resource allocation for effective programming in the areas of satisfaction with the healthcare, focused responsiveness, satisfaction with waiting time at the facility, access to better healthcare, UHMA, a reduction in the amount of money spent on healthcare services, and receipt of all prescribed drugs. From these findings of the client satisfaction survey, the agency swung into action and established and formed a task force team that is vested with the responsibility of ensuring that there is much availability of drugs and medical consumables across most of our facilities, because most of the challenges, most of the complaints we've been getting from our enrollees are the non-availability of prescribed drugs. So, and for the fiscal space analysis, as rightly mentioned by the previous presenter, the Yobe population, 46% of Yobe population are dependent population. And for this coverage for the 5 programs, I think the present coverage is not, it's way around 13% of the total population of the state. So we need to get more funds for us to enroll more of this, especially the vulnerable class, into the health insurance scheme. So this fiscal space analysis has really helped us in determining some source of funding for the agency, for the vulnerable program for the agency. And for the outcome survey, the rapid survey aims to determine the level of achievement of the UHC plan outcomes and the factors that influence the level of achievement of the outcomes. And the specific objective of the survey is to assess overall coverage and the care of service access, efficiency in the implementation of the scheme, compliance with the laid down standards, quality of care provided by healthcare participating in the scheme, and also equity in the coverage of the scheme. So as part of the outcome of the final deliverables from the outcome survey is that the agency is supposed to conduct actual costing, because initially during the establishment of the agency, we only adopted and adapted some of the documents, some of the benefit package and the premium from some of the from other states and from NHIA. So we need to conduct our own actual costing and also advocacy for prompt disbursement of equity fund, and frequent training and retraining of health workers on UHC allowable expenses, and also addressing service availability constraints and addressing complaint of stock out of drugs, and strengthening providers documentation process, because we initially signed a service level agreement with enrollers for us to have prompt compliance of the service level agreement. We need to also come together as an agency and the service care provider to also ensure that the strict adherence to our service level agreement developed between the agency and our healthcare providers. Thank you.
Thank you very much, sir. So the feedback from the surveys, the evidence had helped to strengthen the system, build the trust of the people in the system, and ultimately led to better patronage and improved services to your enrollees. I don't know if Mr. Oluchukwu Obele is online from Christian Aid. Is there a way we can confirm that he's online? Okay, so I know that. Okay, great. So I know that Christian Aid does a lot of work with the community. And like the last speaker had just said, we find that we have a higher proportion of vulnerable people in most states in Nigeria. So based on the work Christian Aid has been doing, what lessons have you learned in terms of optimizing health service utilization by the poor and vulnerable? What lessons have you learned in terms of optimizing health service utilization by the poor and the vulnerable?
Good afternoon, everybody. Thank you for that question. Just to also apologize for the absence of Tokbe. He's currently engaged in another meeting and he needed me to sit in for him. So back to your question. Sometime in late 2020, we're just coming out from the COVID lockdown. Christian Aid, through its health portfolio, decided to look at the work we've been doing around universal health coverage and see what has been our attribution in terms of the success rate. So through the consult, DGI Consult, we did that from November, and by January 2021, the results came out, and that gave birth to the Universal Health Coverage Local Government Initiative. And since then, since that financial year, we've been throwing our money behind that context. We've been basically standing with the people, and not just the people, we've been working with the informal sector. And our work has been basically within Plateau, Benue, and Kefi. But we have optimized our service in Nasarawa, seeing some of the results that we have gotten from that particular state. So in terms of optimizing health service utilization for the poor and vulnerable, in the course of the 2 years we have worked within the states, we have seen that for health financing, we can't run away from that. We can't stop talking about that. The basic healthcare fund cannot only be funded by government. We have seen that subsidization of healthcare through diverse means is a means of getting everybody covered under the umbrella of the health intervention. And what are those sources? Philanthropy, donor funding, whatever name we might call it, personal investment and the rest of them. Those areas helped to scale up in terms of utilization for the states where we intervene. Dr. Gwamina is just sitting right there and he can testify. With the intervention of PSI and also Christian Aid, when his agency was taken up, that was a huge boost, particularly for that agency in terms of capitation and also in terms of the fiscal utilization of healthcare services. So we can't run away from that. So we need to expand our pool in terms of getting more funds from people to help boost what government is already doing. Just like Dr. Dule said, all contexts are not the same. We have come to know that because we recently scaled up to FCT and we wanted to copy and paste what we are doing in Nasarawa in FCT, and we found out that there's a huge contextual difference. And we needed to double back and start replanning what we're doing. So that has really helped us, although it is late, but we're gradually getting there. In terms of getting health insurance for the vulnerable, we have also found that in terms of optimization, paying premium for the poor and vulnerable does not necessarily translate to them utilizing the health services. So we also got involved in terms of health promotion activities, where through the foundation, we've been able to develop a pool of local resource persons who are driving this in terms of resource mobilization within the context of their environment, and also pushing advocacy actions that are helping to break even for what is happening between the health insurance agency and the access to the poor. That has given room to the mistrust that we noticed. That was one of the challenges when we started. People are beginning to see testimonies from within their community, people who have accessed healthcare services, and they are testifying that this works. Now, more persons from the informal sector are beginning to buy for either their members or buy for themselves, or either buy for people who are vulnerable. What we also did to optimize healthcare services for the poor and vulnerable was bridging the gap between the clients, the service provider, and the agency. And what I mean was that we had a monthly service provider forum where clients come to present their challenges to the providers and also in front of the healthcare agency. And that brought some form of accountability, and also was able to provide a feedback to the health agency who was interfacing between the people and also the facility. So the facility saw that it was not business as usual, whereby somebody sits in front of a doctor, he prescribes the drug, he goes to the pharmacy, they say, we don't have that, go and buy it outside. That person presents that case and that facility is queried. Why did you not provide that service to that person? Then when the report for capitation is deducted from your service. So that was a point where they got to that point and they found out that we are accountable for the services that we provide. Just to cap it off before I stop talking, was that this service was community driven. It was not us coming from Abuja to come and do the work, or it was not DGI Foundation coming to come and do the work. It was a resource pool driven, gotten from the community who were driving this particular intervention. And they knew that the intervention was for them and not for us. So even when we rolled back a bit, they continued pushing, and their people continued to access those services, particularly people from the informal sector. And that has given rise to a couple of other benefits for them. We have seen persons from the community adopting more persons and paying for them because they've seen that is a long-lasting benefit where you give somebody access to health, then instead of giving that person on a daily need, you give that person 10,000 to go and solve their problem. That's a 1 year of service, uninterrupted service for that person. So they have seen the benefit for themselves, and that has gone a long way to optimize services for the poor and vulnerable. Thank you.
Thank you so much. Very insightful. The place of community engagement, both for resource mobilization and also for accountability. That is a big lesson out there. And there was something he said when he was speaking. He said that, you know, there are differences in context. When they try to adopt what worked in Nasarawa State to FCT, it wasn't working. And that brings me to the next question, which will be directed to Dr. Folarin Olashoba. We understand that with advances in healthcare, telemedicine has been one of the innovative approaches towards ensuring that a larger number of people have access to healthcare. But we understand that the Nigerian context might be different from other areas where telemedicine has been deployed. So my question is, how best can telemedicine be mainstreamed into the health system in Nigeria, considering the context and the situational analysis, where the issues with the structures and systems and technology that we have available? How can telemedicine be mainstreamed into the health system to be able to optimize health resources in Nigeria?
Thank you very much. I think I'll start from the known to the unknown. Maybe I will just start by sharing our experience as telemedicine provider. Even though telemedicine has been around for decades, but the adoption was during the COVID pandemic. We have had engagements, I mean, prior to the COVID-19 pandemic, but governments and private institutions saw the need for it during the pandemic. And one of the concerns initially was that how do you implement telemedicine, just like you have said. We started into it to understand the system. We didn't just bring the technology from abroad. We understand the system and adapted it to ensure that it can work within the system. When we partnered with Lagos State, because at the peak of the pandemic, many people were locked down. Those who were not even infected or tested positive for COVID-19 could not even access basic medical care. Why providers don't even want to see patients who have fever for the fear of COVID-19. Patients also don't want to go to the hospital for the fear of contracting COVID-19. And government felt that we still need to deliver medical services to the teeming population, more so that there were so many myths surrounding COVID-19 at that time. Not so much was known and there was so much information. So government felt like, how do we reach the people? Because Lagos State, as it were, was the epicenter of the pandemic. And we approached Lagos State government, and some of the concerns we raised, very valid concerns, was that so people don't have access to, not everybody has access to technology. And we told them that it doesn't have to be through video call. You can do this via audio call. And the next question was, okay, some people might not be able to call if they don't have credit on their phone. We told them this is something that the line is toll-free, so you don't need to have credit on your phone to be able to call. The concern of language barrier was also raised, like how do people who don't speak English access your service? We told them that we also provide these services in 3 major languages in Nigeria: Hausa, Igbo, Yoruba. And then the confidence of, okay, let's even see how this will work, how this will pan out. We took up that project and we had to demystify many of the meets around COVID-19 after the guidelines and protocols set by Lagos State government. People were calling in freely. So the fear of, well, I don't have enough credit, I want to end the call quickly is not there. You have relaxed when you're making that call. And the doctor, so when you hear any information concerned around COVID-19, we're able to disseminate health education to a large population around that period. Then the second phase was when people who were tested positive but not apparently sick were occupying many of the isolation centers bed, and you see them, yes, they've tested positive, but they are not apparently sick. And then they play music, they dance, they eat government food on the bed. Why those who are acutely ill don't have bed space in the hospital? Government had to retweak its approach in order to optimize resources and ensure that those who are not acutely ill can be managed from home. And that was when we started the home-based care. Of course, we took up this project again at that time. And what we're doing was to reach out to people who have tested positive and monitor them based on protocol that have been designed on 24, 48 hours basis, depending on the feedback we are getting from them. And we're able to alert the evacuation team or the surveillance team when we notice any deterioration of their condition. We're able to guide them as to those who are living with them. And this, to a large extent, we're able to reduce the number of unnecessary admission, as it were, at that time. And even when we had the third wave, where we have the Delta strain and some countries were designated as red zone. So as they were coming into the country, again, that was also something that we're able to manage, from sending them SMS, reaching out to them. Now, private organizations began to see the need for them to be able to render medical services to their employees or even HMOs. And then they began to reach out to us and say, how do we adopt this? And the major concern was the problem of the issue around cost. You know, there was a time in this country that it was almost, it was said to be impossible to do per second billing for telecom companies. But it got to a point where we broke that jinx. And today, the SIM, per second billing is a normal thing. And even that SIM that was very expensive, out of the reach of the common man, is not something they are offering us free of charge. We were able to demonstrate to them that we can get to that using telemedicine. And today, many of the HMO came on board. Even after the COVID-19, many of them are cashing out using telemedicine provision to attract their members. Now, how do we take this down to the community? Because the tendency.
Sorry, Doctor. We are actually hard pressed for time, and
okay,
I don't know if
I'll round up. Just to get to where the question you actually, how do we ensure that this is taken to the communities or the local community where the technology may not be available, the technical expertise and all of that? Over time, I have told organizations, agencies that there's nothing, just like somebody said, let's do what is known. Let's move from what is known to what is unknown. We have tested this at different levels. And this interestingly, health is in the concurrent list of the Constitution, so to speak, such that each state can set out laws that will guide delivery of healthcare services. We know that the professionals are not available, is no longer news. Even if at that time we attended to millions of people, and you would agree with me that within the space of 6 months, you will agree with me that even one of the biggest hospitals may not be able to attend to that number in that space of time, regardless of the number of doctors you have. But with technology, you can achieve so much more with few numbers. Many doctors don't want to go to the rural communities for so many reasons: insecurity, lack of infrastructure, language barrier. Now, we came up with the virtual booth system, which is an abridged version of telemedicine, in which case you can deploy this in every 10 kilometers in your community. As someone said that, just the last speaker said that providing health insurance cover is not a guarantee that members will use the service. Because so if you have paid $750 for my health insurance and I have to travel 1,000, to come 1,000 naira to travel to the nearest healthcare provider, I would most likely not want to access that service. And then that money is gone to waste. And you can't blame the healthcare provider who is receiving that capitation simply because the patients are not just coming. So the only way is to ensure that, one of the ways, don't let me say the only way, one of the ways is to ensure that we have this virtual booth that is designed to take care of the local community where would have broken language barrier, would have broken cultural barrier, would have broken cost, because people don't have to pay to access that service. And then people can either make a voice call or walk into the virtual booth where they don't have that technological know-how to access that service through the assistance of a local health assistant that has been trained to so do. Of course, there's so much in this regard, and I believe that state governments need to begin to think outside the box to adopt this kind of measure to address the local needs of the hard-to-reach community, rural and hard-to-reach communities. Thank you very much.
Thank you very much for that contribution. We are almost out of time, as I don't think that we'll be able to take any questions from the audience, but I just want to confirm, can we take any questions from the audience? Dr. Gafar, can we take any questions from the audience? Okay, if we can have 1, 2 questions. Just 2 questions. I don't know, I can't see any hands. Are there any hands up? The first 2, any hands up? Okay, great. So we don't have any questions. That means that the presentations were very clear, apt and straight to the point. Before I invite the chair to give us a high-level synopsis of what has gone on in this session, I just want to invite each person to just give a 30-second final statement, starting from you, sir, by my immediate left. 30 seconds, final statements as we wrap up. Yes.
Okay, thank you very much. My take now is for us as critical stakeholders in the health sector to ensure that services are being provided effectively in the healthcare provider for the little enrollees we have on board. We have little, like I said, we have enrollees for the formal sector. The formal sector enrollment is around 95%. So we need to have quality services so that you increase the uptake, especially under the informal sector program. Thank you.
Thank you, sir. Dr. Aribabu.
Thank you, Ma. As a take-home, 1, allowing teaching hospitals and federal medical centers, tertiary institutions, to be taking care and becoming goalkeepers of malaria instead of their core values of taking up referrals, teaching and research is a waste of health resources. That is one area. The ENHIA will also go with electronic medical records, especially for the private medical facilities, EMR. And if we're able to do this, wastages in printing papers and documents and employ people to carry the garbage up and down will also be avoided as much as possible. And finally, I want to say here that a PPP approach that does not guarantee capacity building one way or the other will end up being a waste of resources. Then audit, education, advocacy. Thank you and God bless.
Thank you, sir. Dr. Abu.
Okay, yeah, all right. So final statement from me is first, because we've not been able to recalibrate our healthcare system to really reflect what the system should look like, we are losing the primary healthcare. And we are losing the primary healthcare in the sense that the primary healthcare facilities are becoming private properties of the facility managers. The facility managers are having so much discretion over these facilities that are in quote public. They take decisions as to what to buy, what to procure. They now even take decisions as to whom to employ, in quote, volunteer health workers. And with that kind of alarms of discretion, individual discretion, dominating the primary healthcare system, corruption is becoming the order of the day. Accountability is becoming no more. And so we need to go back to the drawing board and look at our system, our healthcare system, and put them together into one system. Take the primary healthcare system, which is the bedrock of achieving universal health coverage, fix it back into the system, and let the system operate with the values of what the system should be like. Thank you.
Thank you.
Okay, so I want to end with maybe having us think differently and seeing things differently from a new growing up in a digital world point of view and what digital can do for universal health coverage. First is to have it in mind that digital and mobile technology is a key determinant of health. It hasn't been included, but it must be included. The way you access healthcare is determined currently by digital technology. Two is that we need to begin to invest in the enablers of health. We keep talking digital, 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 but in a lot of the communities, there's no power, there's no digital literacy, data is so expensive. So we must intentionally invest in the digital enablers of digital transformation. It's fundamental, otherwise still we won't make much progress. Third is that we need to begin to intentionally collect data to help build our system. So when you talk about data solidarity, ownership of data, the data belongs to you, the users, but we must be able to pull it together in a system that allows us to use it to develop the entire system. So data as a public good. Last but not the least is that we need to stop having analog policymakers make policies for us that are growing up in a digital world. We need to get the young people engaged and involved and create a seat for them at the table. Let us support us on this journey. I think that is so instrumental because if you look at our system now, it's being created by policymakers that really don't understand the new world that we live in. So we must have the young people have a seat at the table to help us develop the policies of the future and the systems of the future for digital health. Thanks.
Okay, as a closing remark, I think we are at a point where digitalization is the way to go when it comes to delivery of healthcare services, and this can be used to bridge the gap between the scarce human resource for health and the hard-to-reach community in Nigeria. And the earlier we look in this direction and layered it into our health insurance system, the better for us. Come to think of it, in many of the primary healthcare centers, you probably have community health extension worker or people who do not have any knowledge of healthcare, a formal healthcare system delivering medical services. You cannot blame the community because, of course, where there is no alternative, they have to stick to what they have. But just imagine putting a tab in front of that community health extension worker in the primary healthcare center and connecting him to a doctor via voice call, and not too highfalutin, just via voice call, and let the doctor guide in the management of that patient. You will agree with me that the quality of diagnosis and outcome will be far better than when he or she is taking the sole decision without the support of a doctor. Thank you very much.
Thank you, sir. And finally, I want to invite the chair for this session, the Honorable Commissioner of Health, Nasarawa State, to highlight key lessons that will inform policy from this session. Over to you, sir.
Thank you, moderator. our panelists. I think I've been doing more of the like the secretary and leaving the chairman because maybe next time we'll send get some things that we all contributed here. I will take them one after the other and see how to add some things also. We've talked much about using technology, and also my friend on my left side, Dr. Jimmy, took his time at first to talk about the public-private partnership, which I think that is something that we have to begin to look at. That in a way will reduce cost to even the public bus. The healthcare system in the developing world now, all of us know, like NHS, you can count how many places that will have MRI or CT scan that are privately owned, in as much as we think NHS is public driven. If you want to have your MRI done within the next 2-3 days, don't go NHS way, because the queue is long. So most people will always do private, and most of the people that will be doing it for in private, they are NHS staff. So I think what he just said is something that will even make things very easy for us. We can count how many of our teaching hospitals have functional MRI now. Some of them are not even functioning, you know, as sometimes even X-ray at a point, the teaching hospital in Gogolada, just X-ray. You have to go out to go and just have it done. So why can't we formalize it? So we're already doing it, but informally. You know, I've been to a teaching hospital that they prefer you go and do simple tests like full blood count with SynLab. You will know popularly those in Abuja, SynLab. They prefer the reports that are bringing from there than the one from their own lab. So we're in a way doing some of these things, but not formalized. And I think it's something that we have to begin to look at it. Thank God this week is NCH week, and most of us will be there by tomorrow. And although technical session is already going on, there are things that will come up, you know, in the council, which of course involve my colleagues, that's the Honorable Commissioner of Health, and then the Honorable Minister of Health as well. So Dr. Jimmy took his time to discuss that, and I buy into that because it's a strategic way of us delivering our healthcare system. There is an issue of inverse distribution of healthcare workers, more in the rural area compared to those that are found in the more in the urban areas compared to those that are found in rural areas. I have that one even personally. Maybe let me share it just 1 second in Nasarawa. We had trained a good number of obstetricians in the state. We have only one state tertiary health institution. So by the time they came back, we felt that some busy general hospitals, you know, should just have them so that they will help us reduce maternal mortality there. So posted one to Awe, posted two to Akwanga. The one in Awe, every day he comes, he was always complaining. And so when I was made a commissioner, he came, was almost crying for me. I can't stay there. His family, they can go to school, so many reasons. And honestly, I had to just talk to him as a person, because even though I'm from Nasarawa, I doubt if I will be able to stay in a way with my family as a fellow. Of the truth. So I told him the best we can do is to see how we can provide some facilities that will make you stay there. Maybe your family can be in Lafia. And then, you know, so these are some of the challenges you see every day, but we pretend about it and we run away from it. And so we are trying to introduce incentives now in the state to see how to make some of them stay. I have issues of some not really wanting to stay. For us that know Akwanga very well, Akwanga is it's a place that any doctor can stay there. So somebody comes and tells me that my family is in Abuja, and the cost of fuel now to go to Akwanga is quite much. So, you know, I can't stay. The Honorable Commissioner, can I be transferred to Maraba and others, whatever? So if you're the commissioner, what will you do? It's that the person doesn't want to work. You know, because I said, okay, fine. If you are employed to work in Badagry, and you decide to go and live in Ikeja, every day to be going to work. So is he commissioner that will be giving money to fuel your car from Ikeja to go to Badagry? He couldn't answer me. Because Maraba and Akwanga, the person in Maraba can easily get to Akwanga than the person from Ikeja to go to Badagry. For us that know Lagos very well. And that ended the argument. So it's two ways. In as much as we're talking about rural, and then urban, whatever. And then we have some issues again. Greki, PSC here. I was one of the medical officers then in Amak. You see a lot of staff there. And do you know why? Some of them, their husbands work with FCTA, some of them, their husbands work with CBN and others, whatever like that. But just leave Gerki and go up there. There's a village behind Asokoro, Baduma. So there's a PSC there. You're going to see fewer, number of staff there. Why? And that goes to, what my friend from the HPRG talked about. Influence and interference about posting of staff. So someone, feels that he's high up there, wife must be somewhere very close to him, and she's working in primary healthcare. So if you're the one working in the primary healthcare department or local government, what will you do? Or maybe it might be me, commissioner, calling you to tell you that my wife must be posted to the municipal, primary healthcare. What will you do as the in charge of the primary healthcare? You're scared. If you don't do that, I might transfer you and carry you to one, So these are some of the practical things that we see, but there are things we're taking up in Nasarawa, particularly to see how to possibly, sorry, I know that your time is to see how we can introduce some incentives, but there are issues that are common to all of us in the 36 states plus FCT. About corruption, yes, I think in as much as research has been conducted on that, maybe he was just scratching the surface. It's probably more than that. Some approaches have been introducing what development committee to see how to maybe see check and balance, but some of them, if you want to go in detail into the operationalization of BSCPF now, you realize that some of them are driving the cost of the corruption, because they always go and meet the in charge. The money has come, let's share it. It's not for drugs alone, and nobody cares. And of course, battling with insecurity everywhere, so everybody has the excuse not to go to work. All this tells you now that health will never stand alone. Any issue that is surrounding healthcare delivery, it's having pull and push effects from the context that we have here. There has been a lot of discussion about introducing ICT to our healthcare so that it's help facilitate attainment of universal coverage. Beautiful, that's the pressure all over the state. You have vendors, and I think maybe we'll have to reach a consensus because everybody comes to the state with beautiful proposal, and everybody feels that his proposal is the best. This is the only way to go about it. In fact, my colleague then, when I was head insurance, can tell you what they pass through. Sometimes people will have gone to either the governor or governor's spouse to come and meet you and tell you that this is the best solution. Some states have had some vendors imposed on them that solution has nothing to do with what they're doing, or sometimes it's deficient that doesn't give you anything. In fact, even now I have one that has just been, I'm sure if they know I'm in Abuja, they will make sure that they trail me. You understand? They will tell, by the time you start asking simple questions, okay, let me give you an instance. You introduce a solution and you say, any person that is coming to register to access care will have to pay 1,000 per annum. When hospital or the facility to pay for car to access care is just 250. And you're telling them, no, this is not practical. In fact, we want to reach a point where somebody comes to the hospital and doesn't pay a penny. But the person is pushing you and pushing you and pushing you. He knows this person, he knows this person. Is that how we should go? So these are things that, in as much as we present very beautiful, my dear sister, we need to reach a point. It's not just reaching states. What are you bringing to the states? It's just because, you feel the ICT is the cost of now, it must be. And you want to push it on the throat of the states? I think it still now goes back to the political interference, which I want to believe that some of the things we see in the government, even the corruption we're talking about, it's coming from the private sector. The push effect. You bring some ideas and you want to push them, and by force, they must be accepted. And of course, the use of data, which my colleague here talked about. All of us know that. In fact, even in Nasarawa, it has worked. And I'm sure in other states, it has worked. It doesn't just work by improving the system. It even helps you get more resources if you're able to do advocacy, with data, especially to the political class. And I must say that what Christian Aid did in Nasarawa has become something that we even learned from what we did and we're replicating into other local government. Once you're starting anything and the community don't get the good thing you're doing for them, even if you build a good hospital and you say it's free, if they don't know what happens there, they will not go. You have people that had health insurance moving about their cats, but they don't access care because they didn't really know much about it. Sensitization helped, and that has actually improved utilization. And he rightly said it. Even the BSPF utilization pattern, if you see it across the country, some places are still recording 0. And it's because the community ownership is not there. So the community don't feel that this is their own. And sometimes, again, you do some things without their input. You choose a facility in the world that is far away from the larger population of the inhabitants of that world. So that means they will not go. All these are things that when you sit down with communities and you plan from the one with them, you get the best. There has been something about Client Providers Forum, which is wonderful, and we're doing it, it's working. And Christian Aid sponsored that, and DGI has been the frontline technical supporter there, and that's fine. The telemedicine, which was the last, that we talked about, I think maybe it left out some things. As simple as even sending SMS to a woman that is supposed to appear for antenatal care helps. And I thought that was even going to be the first thing, that we should be talking about, telling people that maybe they are diabetic, assess your care, assess your drugs. People that are hypertensive every month, have you checked your BP? Have you gone to check your fasting blood sugar? Or maybe place a call to find out how he's doing. I think these are some of the things that we've been able to get here. It's been a wonderful panel, I must say, and a lot of issues came out of it, but maybe might need another forum, maybe as engagement continue, so that we'll put our ideas together, see how to refine them. There's always no base idea that can work for the 36 states plus FCT. So we have to be context specific. And with that, if every actor, is involved, we can get the best out of it. After all, I've always said, we've got the best brain more than Rwanda that we've been going. We've got the best brain more than Kenya. Even Egypt, you can compete with them. We've got the best brain. Why are we not getting it right? Maybe it's looking or waiting for one messiah like Dr. Gafar that will collate all these ideas and put them together, and then we'll come forge ahead. Thank you very much.
Thank you so much, sir. And thank you once again to every member of the panel. Please, can we have another round of applause for every panelist? And then please, can we stand and take a photo together as we wrap up?
Thank you very much, Dr. Ore, for facilitating this very, very robust and stuff-packed field panel discussion. And I'm sure that every member of everybody attending this conference today, they've learned a lot from this panel, how we are optimizing resources for health, leveraging on digital technology advantages, and so many other things we've heard today. Please, another round of applause for them. Thank you very much, Dr. Ere, for coordinating, for facilitating this forum. I want to quickly recognize, because as the presentations were going on, we had a few other people joined us, both online and here in the hall. And please permit me to also welcome online. She has been with us almost throughout the day. Like Auntie Moji said earlier on, we don't have to be doctors, we don't have to be nurses for us to be champions of health, of healthcare systems. And this person, she's a lawyer, she's a mother, a grandmother. She has been a former First Lady of Kwara State, but she's also very passionate about advancement in universal health coverage. So I want us to recognize the president online of Her Excellency, Mrs. Toyin Saraki, the president founder, Wellbeing Africa. You are welcome, ma. And of course, in our midst today, we have Professor Nasiru Sambo. He's the immediate past executive secretary of the National Health Insurance Scheme. You are welcome, sir. Thank you for joining us. He's in the house. Thank you very much. So we have a little, we are reshuffling our schedule a little, just a little. We have some individuals amongst our midst here who we have really recognized their remarkable contributions in the advancement of universal health coverage in Nigeria. And they are going to be recipients of award here today. But to do justice to that exercise, we are going to have two honorable people amongst us that are going to conduct giving out these awards. And please permit me to introduce the two of them. First in line is our mother, our mentor, somebody many of us will look up to help us with this award ceremony. So please show your hands together for Chief Mrs. Mojima Konjola. Thank you very much. While another person that will be supporting her in this award exercise, Professor Chima Onoka. Please come forward. Professor Chima Onoka, you are going to support Chief Mrs. Mojima Konjola to give out these awards. So we have a number of recipients. We have four recipients of this award today, and I'll be reading out their citations one by one as we call them forward. So the first person I'm going to call out, Dr. Ben Nkechika. He's in the house. Dr. Ben Nkechika is currently the managing director of Almond Healthcare Services Limited, chairman, KGDN Technologies Limited, and the immediate past director general and chief executive officer of the Delta State Contributing Health Commission. He had his early education in Delta State, Nigeria, and proceeded to obtain his medical degree from the University of Benin, Edo State, and also a Master's of Public Health from the University of Nigeria in Nsukka in Enugu State. He has attained many postgraduate courses, including the World Health Organization Advanced Course on Healthcare Financing, Executive Health Innovation Management Program at the Imperial College of Business School and Copenhagen Business School, amongst others. Dr. Nkechika also, in collaboration with Farm Access Foundation, conceptualized and implemented Access to Finance program, which has been recognized as one of the most impactful public-private partnership healthcare intervention in Nigeria. A round of applause for Dr. Nkechika. Congratulations, sir. The second recipient for this award today is no other person than the Honorable Commissioner for Health in Nasarawa State, Dr. Gaza Gwamna. Please come forward. Dr. Gaza Gwamna is the Honorable Commissioner for Health of Nasarawa State. Incidentally, is the immediate past Executive Secretary of Nasarawa State Health Insurance Agency and the immediate past Chairman of the Forum for CES for Shares in Nigeria. He has made many contributions toward the advancement of UHC in Nigeria, and is passionate about functional healthcare delivery system and working to coordinate, support, and promote partnerships and collaborations between stakeholders. Congratulations. A round of applause for him. And the third recipient today is no other person than Professor Mohammed Nasir Sambo. Please come forward, sir. Professor Mohammed Nasir Sambo is a distinguished professor of health policy management with strong bias in healthcare financing. During the 4.5 years of his tenure at the helm of affairs of the authority of NHIS, Professor Sambo introduced several reforms anchored to a 3-point agenda that included value reorientation, transparency and accountability, and accelerating the drive to UHC, which reforms have also really helped in system building in Nigeria. Congratulations, sir. Please, all other members of NHIA, kindly join Professor Sambo to take this picture. It's a very, very important moment for him. My country director, Ma, please, I need you to be in this picture because you're a very strong stakeholder with NHIA. Dr. Lekki, we want you here, please. This is a very glorious moment. Thank you very much. And the final recipient for today's award is Dr. Mohammed Lawan Ghana. He's a trained, one more. So the next recipient is Dr. Mohammed Lawan Ghana. Dr. Mohammed Lawan Ghana is a medical doctor and consultant, community health physician, and an experienced public health practitioner. Dr. Ghana was previously served as the executive secretary of the Yobe State Primary Healthcare Management Board, where he designed and worked with other stakeholders to reform the primary healthcare system. As a demonstration of genuine commitment, focus and people-centered leadership by the administration of His Excellency Governor Malabunu, Dr. Lawan Ghana constructed one of the largest MNCH complexes in the country. As Honorable Commissioner during his first tenure, the state recorded an increase in key MNCH indicators by a range of 60 to 70%, which resulted in Yobe State receiving an award as most improved state in 2022. Congratulations, sir. The last recipient is Dr. Babagana Tijani. Dr. Babagana Tijani is a trained medical doctor with masters in public health from the University of Southwest in the United Kingdom. In the last 3 years of his stewardship as the executive secretary, he was able to lead Yobe State contributing to him to become the fastest growing and one among the leading contributing healthcare agencies in Nigeria, with over 276,000 enrollees as a functional for programs, including 2 donor-funded grants by BMGF and UNICEF for the enrollment of vulnerable groups to ensure that Yobe State is on strategic drive for achieving universal health coverage. Congratulations, Doctor. And as we come to the end of this award, I would like to call on the representative of, I would like to call on Dr. Chima Onoka to give a brief address. However, immediately he gives his address, I'm going to hand over to our traditional ruler who has been with us since morning. He's taking his leave and he wants to address us in just a minute. Thank you very much. Dr. Chima.
Thank you very much. It won't be an address, but I think it's to say to really say congratulations to all the awardees and to remind everyone that is seated around the tables that UHC is a journey and people are going and passing the baton. Today, it's some people receiving awards. Tomorrow, it needs to be the next person on the table. It's a journey, and we all need to contribute to it. And whatever we can do sincerely and honestly to contribute to that journey, let's do it. And I believe that God will bless us as we do that. Thank you very much.
Thank you very much, Dr. Chima. So like I said, our royal father, who has been with us since morning, is about to take his leave. And he wants to give us a 1-minute address. Please permit me to hand over the microphone to His Royal Highness, Dr. Ibrahim Yusuf Serikin-Yaki. Shehu.
Please permit me to stand on the already established protocol because of time. I'm sorry, I love staying till the end of the program, but in fact, they have been waiting for me since 1 o'clock. That even if it's 5 minutes, come and attend this. I'm going down to Suba now. Please accept my apology. Otherwise, it's not my way. I always like to stay as a father and make sure that I monitor whatever has happened. So sorry for that. I'm so much happy, and I've listened to many, and plenty, a lot of grammars today regarding our health. But my point is this. Number one, I love area where we are trying to correct our mistakes. If you don't fall, you may not find it easy to correct. But when you fall, I think you need to take cautions. Look back, what has really fallen you. The idea of abandoning already existing projects or healthcare facility is one of the things that we need to address very, very well. Having said that, we need more advocacy to win the heart of the community people on the importance of assessing the healthcare facility. And at the same time, we also need to use the community authority and the community influencers. We talk of political will. We like it or not. If that one is not there, all those things we have packed together may not have good effect and we may not achieve our desired goal. But not all forms of political will. There are some political will that always cause problem for us in the society. But the real point I'm giving to us, I want us to adopt the system that the education institution has already adopted now. They form what we call SBMC, School-Based Management Committee, whereby you allow the community to own this property you are trying to make use of. That is the system you can use to win the community. That is, in the healthcare place, allow the community to own that facility. Let them know that it's for us. Don't let them think it's for the government. By the time they knew it's for them, nobody wants his own personal thing to spoil. Something that is your own, you won't want it to condemn. You won't want that thing not to go well. So let's have more advocacy to the community and the community leaders. We are very close to the grassroots. By the time you win their heart and let them realize that, yes, these facilities are for you. It is your health that is important to us. That good quality, that accessibility, and that cost, you find out that it will be a little bit easier. For example, when the issue of SBNC came up under the education, I happened to be the person they put as the president for the whole FCT here. When the issue of family planning came in, and still the person they put as the chairman, when the issue of family planning comes up. But what we did, for example, under this political will, I moved in each of these our chairmen in their office. I moved their office. For example, Amak. I told Amak, I say, you are in the municipal area of this state, so I need 10 million from you so that the community will know that there is. And within 5 minutes, that political will was done. Barere Council did the same thing and moved down to Okola and that area. But what I'm trying to say in essence is that, please, let the community be the owners of those things. By the time it's like that, most of these abandoned projects inside the bush, that another governor will come and start a new one. It will not happen. Let them believe that it's our own. Give them access. Involve them in it. They cannot do the technical aspect, but they win the heart of their people and they will assess it. And most of this corruption you are talking of, that they influence it, it will reduce the minimum. I pray God Almighty will guide us and make it easy for us. Thank you very much.
Thank you very much, sir, for that, again, reminder that community ownership, community engagement, advocacy at the community level are essential ingredients in optimizing resources for health in Nigeria. Thank you very much, sir. So we are moving on to our technical session 2, that is focusing on getting the best out of the health workforce in Nigeria. What should we be doing differently? What have we been doing before that are not going on well? And to do justice to this presentation, I'm very, very glad to welcome to the podium someone who I always love his presentation because he's always going straight to the point. Permit me to welcome Dr. Olumide Okunlola, Senior Health Specialist of the World Bank. A round of applause for him.
Thank you very much, Boki. Ladies and gentlemen, it's first a pleasure and delight to acknowledge the presence in our midst, the erstwhile Director General of the National Health Insurance Authority, a reformer and someone who's brought a breath of fresh life into NHIA. Congratulations on your award, DG. So talking about efficiencies, I would like to address this topic from a slightly different lens. Slightly different lens. Next slide, please. It's probably no news to all of us in this room that despite Nigeria's level of wealth, the amount of public financing spent on health is about the lowest in the world. At about 0.5% of GDP, this is particularly low. But that's not just it. You probably cannot spend what you do not have, because again, if you look at the level of Nigeria's wealth and size, its revenue-raising potential is completely unacceptable and one of the lowest again in the world. At about 7% revenue to GDP ratio, this is particularly low. However, that wouldn't really necessarily be the focus of my talk this afternoon. Next slide. But to then show that at such low levels of public expenditure for health, which has translated to health outcomes, you could argue that because there's very little spending, that's correlated to poor health outcomes. But then you look at this slide and you look at countries like Bangladesh, that's even spending less per capita and actually has much, much, much improved health outcomes. So it then means that more money only, whilst more money is certainly part of the solution, much more money would not necessarily be sufficient to take us out of the woods. And that's why I just want us to look at another aspect of this optimization question. Next slide, please. If we look at how countries decide to make improvements in their health outcomes, it usually follows some sort of patterns and arrangements. The UN and some people sitting in New York will say these are global targets. These are SDG targets. These are MDG targets. Even in the development financing world, there's something called the Paris Declaration. So you have first where some kind of global agreements are made. That's then translated in a country like Nigeria, which is a federation where you have the governors, stakeholders, Ministry of Health, then coming together to say, how do we then translate these targets to be meaningful to us as a country? And then you have meetings like this, coordination meetings and all of that, that then ends in a roadmap. That roadmap could be the National Health Development Strategy. We've had a second, the third iteration is in development. But I want to talk about one of the products of this kind of process, which we know as a sector-wide approach. Sector-wide approach. And the reason why I'm following this track amongst all of the products is if you go back to the slide, on Bangladesh, one unique thing, and which is why I'm sharing this, is that Bangladesh is on its 5th cycle of sector-wide approach. Not just that, if you look at the top 5 countries in sub-Saharan Africa that has made the most progress in their health outcomes was because they also undertook the sector-wide approach. Ghana, Zambia, Ethiopia, amongst others, undertook the sector-wide approach. So let's perhaps unpack the sector-wide approach a bit more. So what we have currently is that as it is today in a very large country like Nigeria, even though our government does not spend much, you have an inverted pyramid first, where a lot of money is spent on tertiary, secondary, and very little on primary. But also institutions like myself and other development partners spend outside of government systems and government channels. A key feature of a sector-wide approach starts first with what is a government vision. So government of Nigeria, where does it want to be in terms of its population health outcomes? In a SWOP, that's the first thing that is defined. Where do we want to be as a country? A second thing is that that government is then front and center of its aspirations and ambition. The Ethiopian government says, this is where we want to be as a country. If you're a financier, if you're a development partner, if you're an international financial institution, it's either you're in with us to achieve this goal or not. Because this is our vision, we would have a common result framework that we will use to measure everybody. Of course, you need to use my own system. This is not an easy conversation to have. But as I said, it begins with that common vision. This is essentially how it would work, where a SWOP is well designed, where everybody is aligned towards achieving a common purpose. First, we will align all our funding with government taking the lead. So you got a government of Nigeria saying, I may not have much, but this is what I have. Every other person then follows with its money behind that government of Nigeria money. We will finance the things that have been defined in our vision statement. E.g., if it's matter mortality, that's what we are aligned to doing. Our resource framework, sadly, will not be one for Washington or London. It will be only one for Abuja. In your back end, you can go and disaggregate it however you want. But if we all have one common objective, then we will be sure that we're all headed in the same direction. There are a few technicalities to this. For instance, you may say that maybe for some partners, they might not necessarily say, look, I don't trust the government of Nigeria financial systems or its fiduciary systems. So I may not be able to put my money, something happened to the slide. I may not be able to put my money inside a basket, a common basket. That's okay. You could actually have a virtual or notional pooling, where, yes, your money is not necessarily going into government's own basket, but it's doing exactly the same thing that the government's own financing is doing. It's measured in the same way that government's own financing is measured. It's early days. And I think the reason why this was put on the agenda is because whilst you could optimize human resources for health, optimize commodities and supplies, you could also optimize financing. And if you have countries that have actually been able to utilize this approach to very significant and impactful end, it's probably time for Nigeria to explore this pathway as well. It's early days because for a SWOP to work, we would need strong government leadership. Having that impactful vision, having people who can stand and negotiate with partners and other financial institutions, it will not be a walk in the park. There are risks. It's not a one cap fits all. There are risks. If, for instance, Some partners decide to work in parallel with states. That will undermine the swap, because then states that are under certain imposition to say maybe contribute additional financing to their states, if they're not doing it and working in parallel with another development partner, for instance, then that will be problematic. So pretty much very high level now, but I do hope with the kind of interest of the new leadership at the Ministry of Health to implement a So just to end with what we have been told by the new leadership of the Ministry of Health, where it has now launched based on this I can't find the slide. Anyway, based on this framework, where the government wants to implement the Nigeria Health Sector Renewal Investment Program, which consists of the basic healthcare provision sector-wide approach, and the other pillar will be the Nigeria Industrialization Fund. You might be aware that the leadership has a 4-point agenda. Agenda 1 is looking at governance and institutional reforms. Second is looking at expanding population and improving population health outcomes. Third is to exploit the potential in the healthcare value chain for economic growth. And fourth, for health security and pandemic preparedness. So agendas 1, 2, and 4 are captured under the basic healthcare provision sector-wide approach. And here we have been informed by the coordinating minister that he would like a situation where he aligns government of Nigeria financing behind the financing that is available through development assistance for health. For Nigeria, it might not be much. This is just about 10% of our health expenditure. But it could be impactful if that money, which is currently fragmented and not necessarily aligned one common vision, this approach might perhaps be the kind of change that Nigeria requires. Thank you very much.
Thank you very much, Dr. Lumide. You know, I told you guys that Dr. Lumide was going to go straight to the point. We appreciate your contributions to showcase the implementation of a sector-wide approach for resource optimization in health in Nigeria. So we are moving on to the next presentation. And after this presentation, we are going to have our next panel discussion. This presentation is going to be anchored by Dr. Ismail Jibrin. And he will be addressing transforming human resources for health management through digital technology. A round of applause for Dr. Ismail. You're welcome, sir. Thank you very much, sir.
Good afternoon. Thanks, the MC, for the occasion, and I stand on existing protocol. I know we are all fed, but tired and probably sleepy. So I'll try to not bore us. I'll go straight to the point. We'll be talking briefly about, how health technology can be used to optimize human resource for health. These are some of the outlines of items I'll be discussing about. And I will give some of the experience that we have, had in Gombe, trying to use technology in this manner. So first of all, why digital technology? I mean, why is it important? There has been a lot of talk from the earlier presenters about the importance of digital technology. So I don't want to, reinvent the wheel, but just to show a few pictures. This is a surgical operating room. You can see very well gowned, using, instruments, tech. To most of our politicians, this is investment in health. They have created the operating room, they hired the staff, they provide them with the instruments and the materials that they need to function. And also, we buy very expensive machines and having the staff to run it. However, these staff, how they are managed is another question altogether. So in this kind of scenario, we use a handwritten leave roster to manage this kind of resources. We know for sure that health, human resource for health is the most expensive resource that any healthcare system invests in. And it also is the least managed. You can imagine in this kind of situations, you spend a lot of money on training, equipment, and everything, yet the leave roster, when somebody goes to leave, and this is a true image of the leave roster itself. So we need to do something different if we want to gain different results. This slide is a colorful depiction. I mean, roughly 10,000 dots here. They are of different colors, the same size, different locations. Assuming they represent, a healthcare workforce. And each one has its own area of expertise, the services that healthcare personnel provides. How do you truly coordinate and manage this kind of size? And this is not too big, by the way, using the earlier, tool that we had seen, managing leave roster, this one, this. And for this, it's not just leave management, but also managing many other things like, okay, we cannot see very well again. Well, here we listed some of the services that are provided for HRH management. You'll be screening the candidates, you track the applications, you conduct assessments, and you interview the candidate, optimize staffing, as well as manage their attendance, manage their schedule, pay them, manage their salaries, all this using manual payroll and, managing the size of workforce. You will agree with me that that is practically impossible to be done in any, concerted way. So this is the background upon which a lot of speakers talk about the value that digital technology brings in not only healthcare, not only human resource for health alone, but in the management of healthcare as a whole. So what did we do in Gombe? We picked one or two of these to manage, and specifically human resource for health. Gombe, by way of introduction, is the center of northeastern corner of Nigeria, with a population now more than 3.5. It's estimated as 4.2 million. It's about the 30th smallest state in the country, and it shares border with all of the remaining northeastern states. So there was a new government that came into power in 2019 with campaign promises as normal and a victory lap. But looking here, this was, the stark picture that faced the government. A recurrent revenue of around 62 billion for that year, but So the recurrent expenditure of around 62 billion, but a recurrent revenue of close to 59 billion. So just concentrating on recurrent expenditure alone, there is a 3.67 billion naira deficit. Not to talk about capital expenditures, roads, schools, and the rest. And not even to talk about the amount of money needed to, run the government itself. So this was the reality. And looking at the wage bill, it appears to be the largest drain on the resources. So here you can see the population of the workers themselves compared to the large population, they are about only 1.6% of the population. Yet the amount of money paid to salaries is around 58% of the total revenue of the state. So certainly this is unsustainable and something has to be done urgently. This is not peculiar to Gombe State alone. Most of the states, except maybe Borno, they have higher recurrent revenue, higher recurrent expenditure compared to the revenue. Some of the states, much higher, and some other states probably close enough. So this is a problem that is global in nature and real as well. So the employee biometric verification program for the state has 4 legs. Employees who are invited, about 60,000 of them. Paperwork was performed to, review their credentials, and we captured documentation of their bio information into the computer, and also captured their biometric data, as well as scanned those documents to freeze them in time. With this, we have a reliable database for all of the employees. And we realized almost 98% of these employees showed up. So the issue of ghost worker syndrome is not really in the verification exercise, as people were able to take buses, to carpool from Lagos to come down to Gombe to attend the verification. So successfully they verified. The ministries that have recorded the highest population, basically health is the highest, bearing in mind that primary health care and the Ministry of Health in total, contribute about 8,000, but education alone is a little bit above 5,000. The total amount spent for salaries on those in health alone is around 713 million every month. So these 2 ministries were the highest to target for reform. Maybe I was too far. So this is the second leg of the exercise. We realize verification by itself alone, which is what most governments do, is insufficient to establish who is a worker, who is not. Therefore, the state implemented a daily biometric attendance program. So employees, first we determined what are the gives and takes for this program. So we designed an absenteeism model which stretched from the most egregious, where you see a deceased person being on the payroll, receiving salary monthly, to the least, which is somebody coming to work, but he's not a very high performer. The size of each band shows roughly the number of people in that band. So there are retirees that were also receiving salaries. Some are on a leave of absence. Some are abroad doing nothing, and they are still on the payroll and receiving salaries. So we decided to put our mark somewhere here so that our intervention should take care of all of this, but may not be sufficient enough to take care of the bands on the right side. So the model that we implemented had 4 parts. First, it is health worker centric, and it is based on threshold to determine whether he's absent or present. We determine if you come 15 days a month, you are present. If not, you are absent. And it's binary. Just come, take attendance. It's a biometric machine. And it's linked to payroll. So your payment of salary is directly determined by your presenteeism. And in the health sector, we emphasized the daily attendance, and initially there was some resistance, but really as the days go by, the employees became very used to it and were okay with it. There was a governance structure for this setup. And this is how the program was governed. There was a biometric committee at the top of it, the steering committee, and there is a biometric technical committee that reviews all submissions from employees to determine whether they were unfairly treated. There is a secretariat that runs it, and there are DEX officers in all the MDAs. There is a Bureau for Public Service Reform, which manages everything under the guidance of HCM. And we have supervisors in the field that manage attendance machine custodians all over the field. These custodians are in the facilities, while the DEX officers are in the MDS. The Treasury House is the seat of the project, while the steering committee is being chaired by the head of service. And this is the cycle, the program cycle. Essentially, at the end of every month, a leave, the employees who submit their leave and transfer requests, when it is approved, we check the employee attendance on the biometric machine. The employee takes attendance and we retrieve data and analyze it. If everything is good, he gets his salary. If there is a problem, he goes to the remediation lane where he receives an SMS notification that you have insufficient attendance this month. And the employee, supports his absence by submitting documents. The technical review committee looks at it. If it approves, sends him an SMS, and then he receives his pay. So each month this happens, and this has happened over the last 3 years. The program has yielded a lot of data for informing decision. The employee data itself, which includes staff ID, the cadre, his location of work, the department, and the rest, do help us in determining recruitment plan, the staff attrition rate, what is the HRH skill mix in each facility, the qualification, and it also informs planning. So also the staff leave information which is managed. It does inform leave planning so that staff do not just go away, say in December or any of the festive months, leaving their facility uncovered. Resumption dates are managed automatically. So if somebody overstayed his leave, the attendance machines will be able to let us know. And the attendance data itself, tells us the time and the date and the location that the person attended. And with this, we can know the early birds, late birds, what is the absenteeism rate, the presenteeism rate, and the attendance pattern on weekends, on weekdays. So a lot of data that can be analyzed to be used to inform decision was collated. And all of this was linked to the payroll, and we can be able to make sentences about, the wage comparison to benchmark, and whether the adequacy of the wage itself and the trend of the wage compared to, the national average. So These are some of the major decisions that were implemented through the program. The absenteeism rate was detected and remediated promptly. Presenteeism was rewarded. A lot of promotions were made, which were backlogged, and cash as well as kind rewards were given. Additional recruitment was made because vacancies were created and detected. There are a lot of adherence now to the civil service rules, and there is a plan for additional large-scale recruitment. Without the data, such would have been probably impossible. There is a productivity enhancement part to this project that the BMGF was proposing to work together with us to add, because this only tells you somebody comes to work and you don't know what he does during the work, how long he stays, and how productive he is. So this part is going to add to this model 2 additional components, which is taking the patient's visitation using the same biometric attendance machine, and also recording the services, capturing the services that were given to the patient electronically. With this, we can who came, when he came, how long he stays, what he did, how many patients he saw, be able to track patients and trend whether they missed appointments and all of that, adding those 2 models, 2 components. And this, we hope, is going to start in the first quarter of 2024. With that addition, we are going to get additional data to inform further decision making, because we now have client registration data and visitation data. So we can be able to make statements about volume of visit, facilities, volume, healthcare worker service productivity type, and the rest. And this is a slide that summarizes all of the program. Essentially, the most important inputs are here. Political will is big. This is a very politically charged topic, and employees never want to be told they have to come to work or their salary can suffer if they don't. Financing is important, and then the right personnel and the right technology, because this is a very massive program. Currently, Gombe State is deploying 4,000 biometric machines across the whole state to cover every single government office. Activities for a state that needs to start these programs will include landscape assessment, as well as determining the level of implementation over the absenteeism model that I discussed earlier. There will be need for capacity building, and there is need for, way to capture this data, including remote areas. You support the equipments with infrastructure, electricity, internet. We have, resolved a lot of these issues, but I must confess they were not easy. Then there is need for the decision support meetings that would have to happen on a regular basis. Output data received, and then outcomes. Finally, this is the final impact that is expected or hoped: improved health indices. And thank you very much.
Thank you very much, Dr. Jibrin, for that very wonderful presentation. Again, we can see what technology has done to improve human resource for health management. This is a very, very critical time for us to look inwards and see how we can continue to leverage on digital technology to optimize resources for health. So like I promised all of us that after this presentation, we're going to go to the final panel session of the day. We are also, for the last presentation, we are transitioning it into a panel discussion. And of course, I'm going to humbly moderate that panel discussion, and I would like to call on other members of the panel to join us. And I promise all of us that for each panelist, we are going to spend just 3 minutes each So, and we assure everybody that it's going to be a worthwhile period for us. So we already have Dr. Ismail Jibrin seated. Thank you very much, sir. Permit me to call on other panelists for this session. I want to call on Dr. Ufoma Festus Omobi. Please join us on the podium for this panel discussion. And Dr. Bolanle Olushola Faleye, Chief of Party USAID LHSS. Ma, please, we are expecting you here. Dr. Fatai Ogunlayi. Yeah, also, he's online. He's going to join us for this panel discussion. Dr. Fatai is online. Please confirm if he's online. Thank you. Then, of course, Madam Sekinat, please come up. You are joining us for this panel discussion. Please come on. Do we have Dr. Ufoma in the house? All right. You're welcome, sir. So like I said, this panel discussion is going to last just for 3 minutes for each person, and we'll make it as insightful and informative as purpose. Okay, so and the last person I'm supposed to invite is the chairman of this panel, like we had the previous panel. Yes, I'm so sorry, sir. We have a panel, a session chair, Dr. Mohammed Mustafa Leki. You're welcome, sir. A round of applause for him. Thank you very much. So we are going to do justice to that session. And permit me to actually start again from Dr. Ismail Jibrin, sir. I'll be starting with you because you just gave your presentation, sir. And, you know, within the next 2 to 3 minutes, sir, how would you advise other states that want